Well, howdy, everyone. It's right at the top of the hour. So I'm David Glazer. I'm here with my colleagues, Katie Ilton and Ryan Johnson, who I think are muted, but maybe they can say a fast hi.
Hello.
Hi, everyone.
So thank you for joining us. Please bear with us. As much as you are, I'm sure, are in uncharted territory, so are we. We usually do our webinars next to each other. And for example, when Katie or Ryan are rolling their eyes at me, I can see it. And now I'm just going to have to imagine it. So we're winging it a bit here, both technologically and legally. And I'm sure you are too. But we wanted to try to take some time to let you hear what we've learned in the last couple of weeks about COVID-19 from a legal basis. Only one administrative note. I saw amongst the many people who are signed up, there are some manufacturing companies and some food vendors and the like. And so I just want you guys to know kind of what we're going to cover so people can choose. To start off, the first 5 minutes will probably be relevant for almost anyone in any industry. We're going to talk just a little bit about sort of general how to approach the situation. Then we're mostly going to be diving into health law specific information. And so after I do a little bit of an entry, Ryan's going to talk about telehealth, both on the Medicare and Medicaid front. Then Katie's going to go through some licensure and DEA issues. I'm going to walk through some of what rules are suspended, and then Katie will echo talking about HIPAA and EMTALA. And we'll talk about EMTALA a couple times because it's one of the hardest things I've ever done. And then we'll end with some kind of employment questions, talk about what states are doing, talk about questions related to like patient abandonment and patients and globals, and we'll try to answer your questions. So just to start, I never ever give disclaimers. I never have done a, this is only my opinion. I'm going to do a disclaimer here for part of what I say, because part of what you're going to get from me right now is Glazer opinion. We are entering uncharted territory. And some of this may come from me having watched too much MASH when I was a kid, but I'm a big believer in the triage, and I think we're going to be entering a period where some triaging is necessary. First, the legal questions are going to be really hard. I believe we've, between us, spent 10 hours uncompensated in the last couple of days trying to figure out the EMTALA question that we'll talk about in a bit. It's really hard. I think we have the answer. I'll just say I got it wrong twice. And I think we've gotten to the right place now, but it's hard enough. If you Google it, there's about an 80% chance that the thing you read on Google will be wrong. That's the bad news. Here's the good news. It may not matter so much. So I apologize to those who saw this on my LinkedIn thing or on Facebook, because I'm going to reuse this analogy, but as a storm chaser, I like it. If you're sitting at a red light and you look up in a rearview mirror and you see coming at you something that looks like a tornado, and maybe you're not totally sure it's a tornado, but it sure looks like one. And you're not 100% sure it's moving toward you, but you think it is. What do? Do you sit at the light? Do you just go? I would pick a third option, which is I would look to the left, I would look to the right, see if it looks safe. And if it looks safe, I'm going to go. I'm going to make the decision that at this moment in time, the rule is less important than my safety. And that's how I would approach this, right? Now, that doesn't mean you just go through every time, right? There's a bunch of judgment that's going to have to be made. You have to decide the thing probably is a tornado. You have to decide that the best course is to go, that there isn't a semi bearing down on you. I think we're going to have decisions to make like that. Now, this is a Glazer opinion, as I said. This is, I was talking with Steve Beck, one of our colleagues this morning, and he's not totally in the same place I am, although he's pretty close. But I think different people will draw different lines as to when to say, just do it. We're going to talk about EMTALA quite a bit, and I think where we're going to get to is that the law, and even what CMS thinks the law is right now, aren't the same. I think that the people at CMS think that they have given more flexibility than the waiver does. And that's going to be there a lot. And so I think we're going to have to make decisions on what to do. And sometimes you're going to want to call us and back it up. You're going to want to have some record in the file of why you made the decision. Another option that I think is going to be out there is if you have to make a decision and you're not sure what the right thing to do is, be very upfront about it and disclose to whoever the agency in question is that you're doing it. You know, you want to provide telehealth to a private insurer, right? And Ryan's going to talk about telehealth with the government and stuff like that, but every private insurer is doing their own thing. So what do? Well, one option that's always available to you is you send an email to the payer and say, hey, look, in light of COVID-19, this is what we're going to do. And at least you've set it up to make it a lot easier if someone attacks you later that you were public, you were trying to do the right thing, and I think the odds ultimately of someone questioning you are going to be fairly low if you were reasonable, because everyone knows this is a trying time. Now, this is also another Glazer opinion, but I think that this sort of legal principle goes a little bit of both ways. Sometimes we will disregard the law and do something because it's right. There might be other times where, even though something is legal, you may choose not to do it. And this is totally opinion, right? When you call us, we will give you what we think the law is. But I will give you a real world example. I got a call from a client yesterday in a state where there is an order in place to suspend elective procedures. And the client said, can we, before that order takes effect in 72 hours, just ramp up the elective procedures and get a whole bunch done? And the legal answer to that question is, yes, you can. The order is not in effect and you can do it. Now, my personal response to that is the reason that order is in place is there isn't enough personal protective equipment to be able to treat patients going forward, we fear. And we're going to be in situations where medical professionals are going to be on the front lines without the safety we want them to have. And I know from a personal level, I don't want to be part of that problem. I don't want to contribute to that. And so I would want the calculus to be made, is this elective procedure important enough to know that I might be causing some doctor or nurse to treat a COVID patient without protection, right? And that's the calculus I personally would want to go through, and I frankly hope many others will go through, but it isn't a legal question. And so we're going to get asked lots of questions and have to make snap judgments, and those will be partially legal, and they will be partially ethical. You know, so the law is going to matter a little bit less, but it isn't going to be irrelevant. So that was a long windup. Now it's time to start getting into a little bit more of the substance. So first substantive question. When you think about all of this stuff, it's good to break things into rules versus guidance. And regular webinar listeners, and I know we have some first-time listeners, we do webinars every month, and our old ones are available online. They're always free. So you can go back and watch some of the old ones. But we've done webinars about where manuals fit in the hierarchy. When the CDC comes out and says, we recommend that you cancel elective procedures, that generally isn't going to be a requirement. If a governor issues an order, it will. When the president says, don't have a meeting with 10 people, I got a call from a client that said, hey, we're going to get our shareholders together. There are 12 of them. Can we meet in a room? And the answer is, yes, you can. I wouldn't. You know, personally, I would see if you could do that via Zoom as we're doing this right now. But the fact that the president recommended it isn't a law, right? And so there are guidelines and there are rules. I think we often want to follow those guidelines. I am not saying disregard them. It isn't a rule. It's also helpful to break questions into, can we do it versus can we get paid? So as soon as I'm done with this idea, I'm going to turn it over to Ryan, and he's going to talk about telehealth. And within that, there are going to be, you know, can you do telehealth will generally be a yes with the asterisk of there might be licensure issues, and we'll talk about those. But can, you know, right now, I can call a doctor in Minnesota, and if the doctor's licensed in Minnesota and I'm in Minnesota, it's crystal clear that doctor can treat me via telehealth. There just might not be payment for it, right? And so what I think is going to happen is we are going to hit an area where a period where people are going to be a little bit more flexibility, but there will be uncertainty. And I'm going to turn it over to Ryan here, who will talk about telehealth, which, while better than, say, EMTALA, is still rife with a fair amount of uncertainty. Ryan, take it away.
All right, thanks, David. Hi, everyone. So today I'm going to cover, as David mentioned, some recent updates to federal telehealth policy, which were based on the need to limit further exposure and the spread of COVID-19, especially in healthcare facilities. We've had a number of clients, including physician practices, expand their telehealth offerings or start offering telehealth for the first time in direct response to the current crisis. And I think many of these clients would have done so even without the recent changes to telehealth policy and making reimbursement available, simply because doing so is good for patients, good for the healthcare providers and their staff who are on the front lines and could be encountering patients with COVID-19. And it's also good for public health, as we've all heard, by helping to flatten the curve. Which gets back to one of our main points. As David mentioned, we're in somewhat uncharted territory here, a global pandemic, a national emergency with limited resources to confront this expanding threat. And it's not always going to be clear that existing laws and regulations, including the new guidance we've received, expressly authorize or permit what might clearly seem like the right thing to do for patients, for providers, and the public. But it's still important to understand the old and the new laws to make sure you can make an informed decision with some understanding of the risks involved as you respond to the crisis. Okay, so moving on to some recent changes to telehealth law. So the federal government has expanded Medicare coverage for telehealth during the current emergency in a couple of ways. First, by changing the law to allow telehealth to be provided to patients, Medicare patients, in their homes, by allowing qualified providers to use smartphones and apps like FaceTime and Skype to provide telehealth services to Medicare patients, removing certain state licensing barriers to telehealth, which Katie will be discussing in more detail later in the webinar, by permitting the waiver of co-payments and deductibles for telehealth services without running afoul of the fraud and abuse rules, and allowing certain uses and disclosures of PHI under HIPAA that would otherwise not be permitted. Let's quickly take a look at some of the details of each of these changes. First, again, site of service. Prior to the recent changes, Medicare reimbursement for telehealth was very limited, generally available only when the patients receiving telehealth were located at an eligible originating site, which required the patient to be in a medical facility or a rural area, and patient homes were not included as eligible originating sites, meaning that Medicare reimbursement was not available for telehealth services provided to patients in their homes, with some limited exceptions for virtual check-ins and e-visits. So the recent changes now allow qualified providers to provide telehealth services to patients in their homes, which again is going to help limit the number of patients and visitors in healthcare facilities, which hopefully will in turn help limit the spread of COVID-19. Okay, the second change is that now providers can use smartphones to provide telehealth services to Medicare patients. Medicare previously prohibited the use of telephones to provide telehealth services. Again, the recent changes do allow the use of smartphones, those that provide for two-way, real-time, interactive communications. Those can be used during the current emergency for telehealth services. This means that qualified providers can use, and their patients can use apps like FaceTime or Skype, making it much easier to provide telehealth to patients in their homes. Okay, a third change is that new patients are probably okay. So existing or the old statutory language requires there be a pre-existing relationship between a qualified provider and the Medicare patient receiving telehealth services. CMS has asked providers to ignore the statutory requirement and has assured providers that it will not conduct any audits to verify the existence of a pre-existing relationship with patients during the COVID-19 emergency. So again, the statute says one thing, CMS says ignore it. We want to make sure that qualified providers provide telehealth services to patients in their homes, be they existing patients or new patients. Some quick questions we often get for telehealth: what services are eligible? Well, the new guidance covers all telehealth services, not just COVID-19 related services, and qualified providers may provide a wide range of telehealth services, including routine office visits for evaluation and management, mental health counseling, and preventative screenings. Another question: who can provide the services? Qualified providers include physicians and certain non-physician practitioners, such as nurse practitioners, physician assistants, and certified nurse midwives. Other practitioners, including certified nurse anesthetists, licensed clinical social workers, clinical psychologists, registered dietitian or nutrition professionals, may also furnish certain services within the scope of their practice and consistent with Medicare benefit rules that apply to those services. None of this is changed by the waiver. Another question we often get is, how much does Medicare pay for telehealth? Well, it pays the same amount for telehealth services as it would if the service were furnished in person. And for those services that have different rates, for in-office services versus at a facility, Medicare uses the facility payment rate when services are furnished via telehealth. Another question
Ryan,
we get are benefit. Yeah.
Ryan, I'm going to jump in there just to say something that has historically confused me on telehealth or made this hard is that there's sort of a distinction between the payment for this telehealth service and then there is reimbursement for like the telehealth equipment. And one of the things to keep in mind is that that separate payment for telehealth equipment isn't used. You don't get that. There isn't anything for that if the patient is calling from his or her phone. And it makes sense. It's logical. But that's just sort of a change from the other sorts of telehealth where there's like a reimbursement for the act of doing it via telehealth, correct?
Yep, that's a great point. Yep. So a question we also get is about beneficiary out-of-pocket costs for telehealth. The use of telehealth does not change the out-of-pocket cost for beneficiaries under Medicare. However, there is new guidance that allows providers to waive co-payments and deductibles for telehealth services, again, without running afoul of the fraud and abuse rules. Katie's going to cover some licensure issues and prescribing of controlled substances via telehealth. Before we move on to Katie, just a quick couple of comments about Medicaid and commercial payers. First, under Medicaid, many states do restrict Medicaid reimbursement for telehealth, but this is changing quickly as state leaders confront the current crisis. Note that states have broad flexibility to cover telehealth through Medicaid, and no federal approval is needed for state Medicaid programs to reimburse providers for telehealth services. And again, states are rapidly expanding telehealth coverage and reimbursement in a number of ways. For example, Michigan's allowing reimbursement when patients receive service in their homes. New York is now allowing telephonic visits. There are many changes happening across the U.S. with state Medicaid programs. I expect to see more changes as everyone tries to increase the bandwidth, keep patients at home, and make it easier for providers and patients to use telehealth services. The same goes with commercial payers. They're often liberalizing the requirements for telehealth, reducing, often limiting certain co-payments required for telehealth visits, waiving co-payments or fees associated with testing. Again, every payer is different, and going back to what David said, if you have a question about a specific payer and the answer is unclear, shoot them an email, let them know what you're going to do, and see if you can get some guidance from them on reimbursement. But again, things are changing pretty quickly on the commercial payment side, as well as with Medicaid. And with that, I will hand the mic to Katie.
Hello, everyone. A couple housekeeping notes here. We are definitely going to go over our 30 minutes, our kind of anticipated 30 minutes. We have enough content here and it looks like enough questions coming in. So just an FYI. Remember, though, that this is recorded. So you will get a link to the recording after we're done. You can forward it, listen to it for free, etc. So don't panic if you have to jump off. You can listen to it later. We don't have a webinar, we don't have a PowerPoint for you, but we do have a list of the different regulations, guidance pieces, waivers, that many of them that we're going to be talking about today. We do have that in one place, and we'll send you a document or an email with all of those links, and so that you can look more questions up as you have them. So, all right, so this question of licensure, and I'm talking about individual practitioner licensure, has come up a lot. And that's because, professional licensure is certainly a state-by-state issue, but it's implicated in payment regimes, as well as just the question of whether you can do something in a particular state. And most states say that in order for a practitioner to provide services to someone in that state, whether it be via, in person, via telemedicine, or even over the phone, that the practitioner has to be licensed in that state. That's obviously the general rule, and isn't the case everywhere, but that's what we see most often. And clearly, with this crisis, we're getting tons of questions about whether we care about the fact that those local state laws are still requiring licensure in the state. So the question is different for payment than it is from can you do it. So Medicare has said, as Ryan said, the practitioner doesn't have to be licensed in the state to provide telehealth services to a patient in the state. They waived that requirement for payment purposes, but you still have the professional licensure board on the ground who could arguably take issue with the fact that you're doing something across state lines that you're not supposed to be doing. And over the past 2 weeks, we've seen this kind of evolve, and slowly many states are starting to say, look, we'll waive these licensure requirements. Or we'll tell our state boards that they can waive the licensure requirements as they see fit. I don't have a good resource to give to you that's keeping very close track of this, but I think it's changing daily. I think a few days ago I could have named like 8 different states that had expressly waived certain healthcare provider licensing requirements. Arizona, California, Florida, Louisiana, North Carolina are a few of them. If you have this question, you can, we can look at it for you, or you can try to talk to the state or just and see if there's been any development. I think that the broader question that David raised remains, which is treating people in certain states where you would otherwise be prohibited, is it necessary to help out in this crisis? It doesn't mean that you want to blow all rules off, but I would say even if we aren't in this crisis, I've generally thought of practicing in another state via telemedicine to be a fairly low risk type of situation. You don't see a lot of enforcement that way. And I really, really do not anticipate seeing enforcement on this point when people are doing it in the current crisis. So keep an eye on that. A lot of practitioners have, hesitations, and I understand why, but I think it's important to keep it in perspective. On that, a similar point is this question of whether you can prescribe certain drugs. So obviously, again, prescribing is a state-by-state function. Prior to this crisis, there was a federal law in place that is called the Ryan-Haidt Act that basically said nobody could prescribe via controlled substances via telemedicine unless you had seen the patient in person previously. And that was very constraining. And
Katie, I just have to say, how did you not make a joke about Ryan being tall there? But keep going.
Ryan, fair. So the good news is that the DEA came out just this week with an express statement saying that the DEA prohibition on prescribing controlled substances via telemedicine when you have not previously done an in-person exam, that prohibition is gone. So you can prescribe controlled substances under federal law via telemedicine, even if you haven't seen the patient, so long as you're doing it for a legitimate medical purpose, you're using an audio-visual, real-time, two-way interactive communication system, and you're also acting in accordance with state law. That's the federal DEA prescribing permission now. Now I'm gonna circle back to this licensing piece because this concept, because we still have on the books in many states prescription laws that say people can't prescribe controlled substances unless they've done an in-person exam. So now, even though we're in a situation where the DEA is saying, look, you can do it via telemedicine, we're okay with that, you still might have states who are stricter than that. So far, I haven't seen any state except for Ohio that has stricter controlled substance prescribing regulations let up on those. Ohio has eased its restrictions. Now, that doesn't mean that you might not decide, look, we think this is important. Our practitioners are aware of this risk with state law, and we're going to move forward anyway. But be aware that the state law is uneven on this point of prescribing controlled substances and what is required in order to do it. And that while you do have the DEA saying it's okay, there may be some states out there, and right now we haven't seen a lot of them coming along, changing. But again, that could change as the situation evolves. We do have a link to the DEA statement as well in our materials. David, I think you're up.
Okay, so before I dive into some of the substantive rules, I just want to highlight a couple of things. So first, we're getting really good questions and comments, and it's always tough as lawyers. You don't necessarily want to name people unless we know you want to be named. But I want to give credit to the person who just said, regarding telehealth across state lines, malpractice insurers may have coverage limitations. And I want to give credit to that person because honestly, I'll bet Katie's thought of that or Ryan has. I should have probably, but that's an interesting thing that's out there, and it highlights how ridiculously complicated this stuff is, and it's moving so fast. We are flying a little by the seat of our pants here, and there's a lot to think of. I would also put that one, I think ultimately the question is the cocktail party test, right? And this is not the way I practice law very often, but right now, if I was having a dinner party remotely, so no actual dinner parties, but if I were having a Skype dinner party with 10 people and I told them the story, if I thought everyone around that table would agree that what I did made sense, I'm not going to worry about it that much, because ultimately, at some point in any investigative process, you get in front of a bunch of people who are exercising discretion. And so I think it's a great question about the med mal, and it's another one that I would handle, I think, by saying, sending a thing. I might send a thing to my insurer and just say, hey, in this crisis, this is what we're going to do. If they get back to you and say you're not covered, then you have some thinking to do, right? But if you just don't hear from them, you're in really good shape if 2 years from now they try to deny a claim. And so I think that notify people strategy, and make sure you do it in a way, you have a return receipt on your email, or you send it certified mail, or do something that lets you prove that they got it. Okay, now on to some of the substantive rules. And one more disclaimer. So there is a document that's entitled the COVID-19 Emergency Declaration Healthcare Provider fact sheet. Okay, and I sent out a link to it after a Monitor Monday broadcast. I read it. It was helpful. And it's interesting because it doesn't mention EMTALA at all. And the reason it doesn't mention EMTALA at all is that the waivers fall into two categories. Some are general complete waivers and other are discretionary. And Katie's going to talk about this more when it comes to EMTALA, because she has really, dived into this and really worked on it, and it's really hard. But there are some blanket waivers that just generally apply. Those include, if you're a critical access hospital, you can now have more than 25 beds. And the 96-hour requirement, which has been, so the 96-hour requirement is really complicated on its own, but it's the idea that generally speaking, you're not supposed to have someone in the hospital if you expect them to be there more than 96 hours. And that requirement has been under a fair amount of attack. CMS has said that they don't generally plan to enforce it, but they haven't taken it away. Now they've said for right now it's suspended, okay? Generally, as you know, if you want to get into a skilled nursing facility, you need to have a 3-day hospitalization first. That rule is gone. And I've seen people ask, well, can you get admitted out of being an outpatient to a SNF? And I think the answer is yes. I've heard someone I respect say, well, the patient needs to have a skilled condition in order to be admitted. that might be right. I actually am not 100% sure on that, because one of the other things that's happening is that patients aren't going to be required to have minimum data set assessments. So I'm a little stumped on this. And I think one of the places we're going to have to all be on this is willingness to say, not sure just yet. So there's one from me now. If you're an excluded distinct part unit of a hospital, generally you can't kind of commingle. This is different from the space commingling thing that Katie and Breyer have done webinars about, but you can't generally commingle. People who are in a distinct part can't come into the acute care center and vice versa. That's gone. You can treat one patient in the other if it's necessary. In the example, another example of a weird exception that's only partial, there's a waiver for DME that says if DME is lost or destroyed, CMS is waiving the face-to-face requirement and saying you don't need a new order and medical necessity documentation. But note that this only applies to destroyed DME. If a patient needs new DME, that exception isn't there. Now, here is my hypothesis as to why. I think CMS knows that just as some people will buy 17,000 bottles of hand sanitizer and try to sell them for $100, if they got rid of the limit on new DME, some people would suddenly decide that every senior citizen in America needed a wheelchair and they would try to take advantage of it. If you are in good faith going at this, I don't think CMS is going to pick on you for this one, right? But I think they didn't feel like they could offer the waiver because it's subject to abuse. Totally speculation on my part, but it's my theory. Let's see, so CMS is postponing all revalidation and waiving site checks and criminal background checks for new provider enrollment. Now they're going to get to a couple that I can't explain very well because I read them and I scratch my head. So home health agency providers can get relaxed timeframes related to their OASIS transmission, but I couldn't figure out what they were, and no one has asked me, and so I haven't chased that one to ground yet. So I don't know how relaxed that one really is. And then there's something about, there's auto cancellation of requests for automated payments. And I'm totally stumped here, but apparently Macs have the ability to extend that deadline. I just can't tell you more. There are also some mushy appeal flexibility changes. I don't think they're super important. Some of them are really weird, like they're supposed to be more to grant requests for good cause to the full extent possible. And I'm like, well, wasn't that true before? So I don't fully understand it. And I think people right now aren't that focused on appeals, so I'm going to kick that can down the road. So now we're going to come to some of the hardest stuff we're going to talk about. Katie's going to first talk about HIPAA and then terrify us with her EMTALA analysis.
It's always nice to have your partner say your analysis is terrifying. I'm kidding. David says that because the EMTALA question has really been a really tough one for us, and I think getting conflicting guidance. But first, let's start with something that's easier. So the HIPAA and EMTALA questions are coming from the same source, or the waivers are coming from the same source, and that is the Secretary Azar's waiver that was done on March 13th, 2020. That is the first link, I believe, in the list of resources that we sent. And I think when you're analyzing these questions, it's important to pull that up because how it's structured and written really helps us figure out, or at least gives us some clues as to what of the waivers are things that are just, they're waived, no more steps required, they're blanket waivers, applicable now, and what items in that pronouncement must still be waived specifically by CMS. So in the category of what is waived as of, actually it's as of I think March 1st, retroactive to March 1st, by this 1135 waiver, includes the HIPAA items that are included. So without any further steps needing to be taken, HHS has said there are a couple HIPAA things that it's okay if you don't follow the rules. and that is with respect to hospitals. So this isn't just any covered entity, it's a hospital. Any hospital that has a disaster protocol in operation. So I don't know what hospital doesn't have a disaster protocol in operation right now, but for those hospitals, the following HIPAA requirements are not applicable, in that there will not be sanctions and penalties. So you could still do them, but if you didn't, you wouldn't be subject to sanctions. They include the requirement that you get a patient's agreement to speak with their friends or family if they're involved in the care. So you don't need to get consent to do that, and you don't need to necessarily honor a patient's request to opt out of the facility directory. You don't have to distribute, well, if you don't distribute a notice of privacy practices, you're not going to be subject to sanctions in those hospitals. And the patient's right to request privacy restrictions or confidential communications, if you don't comply with that by granting them that right and honoring it, you're not going to be subject to HIPAA sanctions in that case. So be aware of those. You don't need to do anything further to avail yourself of that protection. Moving on to EMTALA, this is trickier because what AZAR has done for EMTALA appears to be set the path or set up the opportunity for CMS to grant case-by-case EMTALA waivers with respect to two requirements of EMTALA. So before we get into whether it has to be case-by-case, I'm just going to tell you what it is that the waiver sets us up to be able to do if CMS agrees. So basically, the waiver says that the entities subject to EMTALA will not be sanctioned for, there are two of them. Number one, directing or relocating an individual to another location to receive medical screening pursuant to an appropriate state emergency preparedness plan. So the first of the two EMTALA potential waivers is with respect to you being able to relocate people to receive their screening if you're doing it pursuant to a state emergency preparedness plan. The second says that the sanctions under EMTALA will be waived if you are transferring an individual who has not been stabilized if the transfer is necessitated by the public health emergency COVID-19. So there are two potential waivers. The one deals with medical screening in a different location pursuant to some state preparedness plan, and the other deals with the requirement, the typical requirement that you stabilize a patient before you transfer them to another hospital that accepts them. So that's what is potentially waived. The big question out there, and that we've been debating for a long time, or the last several hours, and that if you were to poll the law firm sort of commentary on this, I think you'd find half of health law firms think basically the waiver is set. You don't need to do anything more. It's available to all hospitals. And then the other half would say, no, this is a case-by-case waiver. The waiver can be applied, but only if you ask CMS to give it to you specifically. Where I think we come out based on how this waiver is put together. And again, this really requires you to look closely at the waiver text, the March 13th waiver text. Where we come out is we think, as it's written, the available EMTALA waivers that I just described are not available to everyone. They have to be granted with respect to your facility by CMS. And that's because in the intro to that section, it discusses how the following requirements are waived, but in each case, only to the extent necessary as determined by CMS. So what is this?
And I'm just going to chime in, Katie, to say there are, I think you'll know this, but I think there are 3 sections in the waiver, and the next 2 don't have that language that Katie just read. suggesting that the EMTALA stuff is treated differently than some of the other stuff.
Yeah, actually, it's interesting because what I just read is an intro that arguably applies to all of those sections, A, B, C, D, and E, and C is the EMTALA section. But then later in D, which is the Stark, I guess the Stark enforcement, that one has the qualifying language about CMS determining it and having to determine it's appropriate. So it's really, I guess it's sloppy.
Right, but 2 and 3 don't have that language, is all I'm saying.
Right. There you go. Yep, I understand what you're saying. So what does this mean? If you are a hospital and you have plans or want to explore plans to set up different medical screening locations, or to be able to transfer people who you haven't necessarily stabilized, for example, to a location where you've decided to put COVID patients, or a location where you're putting, non-COVID patients. What does this mean? I think at this point, I don't think we have clarity from CMS. In fact, right as we were getting ready for this phone call, or for this webinar, I got an email from a client saying, wait a second, CMS told us in a call that we can set up medical screening exams on campus, and that we're going to be okay under EMTALA. We can send people there, and we don't need to ask for a waiver. So I think there is great uncertainty around this. As of today, what I would do is move forward with exploring and developing the right plans for your facility and among hospitals in your community. Ask your state survey agency, your governor, the regional office for the waivers that you want. And maybe, hopefully, if we all text Seema Verma or send her an email, she will explain what we need to do next, because I think right now it's not clear. And in order to set you up for the best success, I think you should take the practical approach of planning of what's best for patients, but also do what you can to get legislators, the state agency, and your advocates on your side of helping you to get these specific waivers until we have further clarity.
And on this EMTALA thing, it's one of the struggles for me on this is kind of recognizing EMTALA's got 2 chunks, right? There's there's the stabilization transfer part, and then there's the sending people home. And what's completely missing from this, and Katie, correct me if I'm wrong, but like if a patient comes in with chest pain, and in a normal situation, you'd keep them overnight for observation. You're pretty confident, their troponin comes back low. You're pretty good. You're pretty certain it's not an MI. But normally you'd keep them in observation just to be sure. But you're full up, right? And you don't want people around because who might be exposed to the virus. And so you kind of think it's in this person's best interest to go home. That is not covered by this waiver at all. Right. And so I think from a practical standpoint, all you can do is say to the patient, look, normally we'd keep you. Right now, I don't think it's a good idea to do that. I recommend you go home. Is there some risk if the person in fact proves to be having an MI, you get in trouble? Yeah, there is under EMTALA or a med-mal thing, but I think you have to exercise your judgment. There clearly is not an EMTALA waiver at this point. You'd have to fall back on the common sense.
I think that's right. And you just have to make sure that if you decide not to ask for any waiver, or if you don't get one, your regulatory argument is narrower than just, we don't have to comply with EMTALA at all because it was all waived. It wasn't all waived. It's just potentially 2 parts of it are waived.
And Katie, I don't know the answer to this, so it's not fair, but do you think, can a regional office give the waiver on the discharge question I was asking, or because the 1135 doesn't go there, do they lack that authority even? I
think they do. I think that this sets the statutory waiver, and that's because 1135, the statute, allows for waivers of certain things for EMTALA, not for waivers of all of EMTALA. And what this language in the Secretary's potential waiver, as I'm calling it, mirrors the statute. And so I don't think the entire EMTALA the entirety of EMTALA can be waived under the statute even to start with.
And I come down
It's
the
an
same
interesting
way.
question though, yeah.
Okay, are we on to nervous employees?
I think so.
And we've got a bunch of questions. It's great, and keep sending them in. And I'm just going to mention as we look at these questions, you know, we are getting lots of questions. We're busy. After this webinar, you can ask us questions. People are sometimes scared of how much it'll cost. Many of these questions, you know, we can answer quickly, and we'll let you know if it's going to require a lot of research. We will let you know, and you can choose. And I think all of us are sensitive to the need people have to be cost sensitive and what's going on. So we're aware of it, and we'll act accordingly. All right, I am not an employment lawyer, but I know a little, and I just kind of cover a few things that have come up for a bunch of our clients. I will preface it by saying I think one of our tasks in the next few months is going to be armchair psychologists. And so let me use a real world example. Nurse says, I won't work next to Dr. X. She was just on a plane back from Florida, and I don't want to be exposed to anyone who flew. Now, I get it, but realistically, Dr. X who was on a plane, she is no different than Dr. X who was in the grocery store, right? You know, and so that level of trepidation, there are going to be people who are nervous about stuff that's not totally rational, and we're going to have to help people understand that and work with it. So if an employee is uncomfortable working, can you make them work? Well, it's going to depend on a lot of things, but it's certainly going to be okay for you to say, if you would like to take time off, you know, unpaid, that's always going to be okay. The flexibility you have, I'd say one of the core principles to go with here is intellectual consistency. If you start treating some people some way and others different ways, that's where employment headaches often originate. I do think it is reasonable to expect people generally to work. And so if people are nervous about their ability to do their job on some of these things, you're going to be able to impose some requirements. They're going to have to be consistent, and we're not going to be able to cover all this because we aren't employment lawyers. But like one of the very first questions we got was someone who asked, hey, can we ask our employees who are working from home to tell us if they start exhibiting symptoms, because we might want to let people know. And as a general rule, you can ask employees most things. There are exceptions to this. You know, you can't, it's not smart probably to ask people about disabilities per se and things like that. But if you want to ask someone, will you let us know if you get sick so we can tell your colleagues? The person can choose not to, right? And I think that at this point, that request is a reasonable one. What about employees who say, I won't work without more protective equipment? I don't have a good answer for that one, right? We're in this place right now where there's where we're going to wind up almost certainly with an equipment shortage. And you know, the first answer is, once again, people don't have to work. They can go home. I'm sort of stumped on this one a little bit more. I don't know, Katie or Ryan, if you want to jump in on this. I think we're in uncharted territory. I will add also, OSHA and the CDC don't have to see things eye to eye. And we're going to have situations where guidance from your local state agency and the CDC and OSHA might be inconsistent. And all you can do there is choose the best course you can. I hear silence. So
I agree with that, David.
So I'm going to move on from that because I feel like I've been remarkably unhelpful, other than saying we're just going to have to kind of chart a course out and do the best we can. Katie, I think you're going to talk a little bit about what some of the states are doing.
Yeah, so I think I'm mostly going to say that every state is doing its own thing, obviously, and that we don't we can't keep track of everything in every state, obviously, but it's changing, I think, even more quickly at the state level. What we've seen, for example, in Minnesota is some expanded coverage requirements that health plans pay for telemedicine when the patient's in their home. Previously, the statute here didn't require us to pay, or insurers to pay, if patients were in their home. We've seen that expanded. Lots of looking to pass legislation that gives the Medicaid commissioner authority to waive licensing requirements, not just for telehealth, but requirements for facilities, background study requirements. You know, in Minnesota, we have direct service professionals who have to have background studies for certain facilities, waiving those or at least relaxing them. Lots of, you know, do you have to have in-person assessments for certain services? Can those be over the phone now? Lots of movement on trying to get rid of or lessen relaxed staffing ratios as people face workforce issues with illness and stretching. We already have a thinly stretched workforce. So reporting requirements, you know, anything that has to be reported to the state, you know, looking to relax those sorts of things. So, you know, this is just keep an eye on your state legislature. It's changing a lot. Those are some of the themes that we've seen, and I'm sure we'll continue to see more.
So we'll do questions in a minute, but I think I've seen literally a dozen questions about coding. And so I just want to answer that specifically right now. In like one of the biggies, what site of service should you use for telehealth visits? And this is one where I would put zero worry into it. We get lots of site of service questions, and the instructions on site of service are often super mushy. They matter when you're talking about the difference between provider-based and clinic, because there's a reimbursement impact. When there's no reimbursement impact, it is hard to get super stressed about site of service. And so we'll look at those. I don't know definitively offhand whether you use home. You know, for many things you use where the butt of it. Well, it's inconsistent. Sometimes it's where the butt of the doctor is, and sometimes it's where the butt of the patient is. But of all the things to get stressed about, I would say that's the least. And so I don't know that I have a definitive answer for you. I just know I wouldn't worry about those. We've gotten a bunch of questions about patients who are like in a global surgical period. Can we do those visits remotely? And this is a particularly nice one because remember, you don't actually have to see a patient in the global. It's bundled, but technically, I mean, you might be malpractice not to see someone, but there's no minimum number of requirements. They're not billable. So those absolutely can be done via telehealth. Getting some questions about patient abandonment. That is an area where I don't feel comfortable saying, I think the rules are off here, right? I think that very much that those rules might continue. And the general principle there and there, it's going to be by state. Most states have a principle, you have to be reasonable. Almost every form letter I see is 30 days. That's kind of made up. You know, but you shouldn't be leaving people in the lurch. And so, you know, to the best of my knowledge, there's no reason to think that patient abandonment things are gone. Now, that said, if you literally can't do it, right, all of your medical staff is sick, no one's going to get mad at you. But if you decide, hey, we're not going into nursing homes anymore, it's scary, I wouldn't be able to tell you that someone couldn't complain that there's abandonment. Katie, I think you got a couple more points, and then we will all go into the questions.
Yeah, just a couple quick short points. There are lots of folks out there who are probably sitting, you know, 4 weeks ago were saying, oh boy, CMS or our accrediting organization, you know, we're at the end of our survey cycle and they haven't shown up yet. They're probably going to show up. So if you're not aware, check out the CMS guidance on how CMS is reprioritizing and suspending some survey activities. It's actually a pretty helpful document. They talk also about how they're coordinating with accrediting organizations. Worth a read, and it's not just, you know, not just nursing homes, but for all accredited institutions. So that's on our resource page. One, you know, for those that have nursing homes, there is a guidance document that I'm certain you've heard about from your trade groups, but it's definitely worth mentioning about infection control, limiting visitors, etc. That's that's also on a resource page, and you could probably do a whole separate hour plus webinar on how to deal with this in the nursing home, long-term care context, and those sorts of things. So as a start, I would look at that document, and if you have specific questions about that area, please let us know and we'll see what we can do to help, because that is just another area that is, you know, it's coming fast and furious, and it's a lot of issues. And then finally, I'll mention something that I haven't even read yet, but that I wanted to make sure you're aware of. It looks like the Secretary basically, Secretary of HHS basically said, we're going to extend liability protection to healthcare providers that are basically working on solutions for this, that are manufacturing, distributing, administering, or using, quote, medical countermeasures to address COVID-19. So this isn't just for drug makers, it's for healthcare providers who might be developing their own sorts of testing. And so if you're one of those types of entities, I would look at this carefully to understand it, because it's not something we've gotten tons of questions about, I don't think, in our group, but it's going to be important to others. I think that's all I have on my list, David.
Okay, let's try diving into some of these questions. And normally we follow up if you don't answer a question during the webinar, we try to at least. I don't think we can make that promise on this one, but you should definitely feel free, if it's something you need an answer to, follow up with any one of us in the Health Law group, right? You can do Ryan, Katie, or me, or anyone else in our group, and we'll do our darndest. So we got a bunch of questions here. We'll try to work through them. I know one that we get a lot of is sort of notifying people about infections. And, you know, Katie, you've dealt with that some. Maybe you want to chime in for a minute.
You mean notifying people if an employee has an infection?
Exactly, yeah, yeah.
Yeah, so, you know, this is the situation where your employment counsel may typically be, and rightly so, conservative about blasting health information about employees to other employees, or at all to anyone. And so if you have an employee who thinks that they have COVID-19, or they've been exposed, or they've been tested and they're awaiting results, or they have a positive test, I think, you know, best way to protect yourself is to ask the employee if you may share that information. Obviously, consent of the person to give the information is best. If you don't have that consent, I think legally you are looking at potential, you know, a theoretical claim that you've shared information about someone's quote disability. In this context, I just don't think that's something I'd lose sleep over, but just be aware that that's sort of the exercise, the academic exercise you go through.
And you don't have to name the person.
Right, you wouldn't have to name, you could mitigate it by not naming the person and all of that sort of thing. Maybe though, you know, there are state laws, for example, Minnesota, just one, says that, you know, anybody who has knowledge of I'm going to butcher the language, but basically a strange potential pandemic illness is supposed to notify the commissioner. Well, obviously the horse has left the barn there, but it may be that even in that sort of disability context, you have some legal defenses because you have other reporting obligations. So it's a icky, sticky kind of question, and I think you're going to be probably taking the practical approach that David talked about at the beginning, which is doing what you think is right and fair in this situation. And
we're about to hit a point where you can assume it's everywhere, and some of that will become less important, sadly.
Right.
There are a bunch of questions about sort of confidentiality and what devices you can use. I know, Ryan, you'll want to comment. I will say two things. One, just know that the law says that the device for a telehealth visit has to be capable of doing audio and visual. It's a little unclear that you have to actually use the visual. And a couple of people have said this, and it's the grandparent test, right? A lot of the seniors either have dumb phones or don't know how to use, they can't use FaceTime or Facebook. or FaceTime to do it, or they can't. So what can you do? So if you do audio only, it may be okay. It's best if it's a smartphone and you choose to use audio only. I think there's a decent argument you're okay. It's not clear. Safest, do something that's visual if you can. Clearly best. I would encourage physicians to say, as long as this is true, I had a communication with the client on a smartphone, even if it was audio only on the smartphone. If it is a dumb phone, I guess you don't want to lie, and you just have to know you might not get reimbursement. And back to can you do it? Yes, it just might not be reimbursed. Ryan, do you want to comment on the classic, well, what about Facebook? What about FaceTime? What about privacy generally on all this stuff? Katie probably can talk too.
Yeah, sure. So just, good question. The government has said that the use of FaceTime and Skype is okay. There is, I think that using Facebook social, Facebook Messenger or other social media apps, I think you would evaluate the security of those. But FaceTime, Skype, Zoom, clearly okay.
And if the patient consents, Katie, does that solve our problem?
Oh, I'm sorry, David, I didn't understand.
If you use a less secure method and the patient is okay with it, if you say to the patient, hey, this may not be secure, are you okay with it? Does that solve your problem?
Helps. Yeah, I think it helps. I don't think technically it solves your security rule problem under HIPAA, but and I failed to mention this earlier, but one of the links that we have on that, and that Ryan just said, is that OCR has said we're not going to enforce our security rule kind of requirements with respect to commonly used applications like FaceTime, et cetera. And this is the one sort of funny, not funny, but at least I got a chuckle out of it. OCR did say you shouldn't use TikTok for these sorts of visits.
I will keep that in mind.
So FaceTime is okay, but not TikTok. The other thing I'd say is, just now I'm sort of getting academic, but what's interesting is I think the DEA requirement or waiver of the requirement that you not prescribe controlled substances may require you to use the visual, but it's not entirely clear.
I think it might for controlled substances, but yeah.
So what that's worth.
I'm going to ask Ryan and Katie, just start looking through. We'll just grab questions here and we'll go. I've got one, which is, CPT gives examples of qualified non-physician healthcare professionals who can't report E&M, like speech-language pathologists, PT, OT, social workers. Can they do these telehealth things? And so first, and I'm going to ask Ryan to comment on this in a second, but E&M, it is important to understand that E&M codes are not the codes that those professionals generally bill. And so, for example, Medicare only lets nurse practitioners, physician assistants, and clinical nurse specialists and physicians bill E&M. A PT can't bill an E&M code. But I believe, and I'll look for Katie and Ryan to back me up, I think those other folks can still do the telehealth under these waivers. It just isn't an E&M code. They'll be using the code they normally do. But I will, and I know, Ryan, you know about PTs.
No, that's correct. And, they can still, as of, actually earlier this week, CMS liberalized what they can do. And so they can do e-visits, using a portal. I had some back and forth with a couple of the attendees in the chat section, and I can try to send that to all attendees.
I just saw, and this is again evolving, I think I just saw a note that a client is going to do, or a client heard someone else is going to do E&Ms via telephones and bill as E&Ms instead of as the virtual check-ins that have been expanded in recent years. So it's, we're in a whole new world here.
And I think you can do that, and it might be a better way to go. I think that works.
Right.
Gosh, I had one and I totally lost my train of thought. So if someone has one, grab it, and I will find this one that I thought was a great question.
I think someone
I know what it was. Go ahead, Katie.
I think someone asked if Medicare and Medicaid telehealth requirements are the same. Well, first of all, someone asked, are telehealth and telemedicine the same thing? And that's a great question. Interrupt me if you have already answered this and I was reading something else. So yes and no. Telehealth is a term of art that Medicare has used. And it's the audio-visual two-way synchronous communication. And when Medicare talks about paying for telemedicine or telehealth, they use the word telehealth. I think that's the only context I know where, well, the DEA, however, uses telemedicine, but I think they have the same description as Medicare's telehealth. So that's what it's been kind of tricky as you look at different licensure statutes, is that each state could have a different definition of what is telemedicine, what is telehealth. So I guess the point is, it's a good question. It's not consistent. And just know that when you're talking about Medicare and the DEA, you do have specific terms that they use. Then I think someone...
Yeah, I'm sorry, go ahead. Because your other one was the one I was trying to think of, and you got it. So go ahead.
Yeah, someone says, are there telehealth? Well, I think there are a couple here. Is Medicare the same as Medicaid with respect to telehealth, telemedicine requirements? And I think the answer is no. There may certainly be and is a lot of overlap, as I've seen, but Medicaid telehealth or telemedicine may be different and have different requirements than the Medicare. So that's a question, and that's why you're seeing a lot of states asking their legislatures or their agencies to waive Medicaid telehealth requirements that are different than Medicare.
And I think that goes to the general point of one of the things that makes our job hard. Medicare, Medicaid, TRICARE/Champus, and every private insurer can have their own rules. And just because you know one, that tells you nothing about any of the others. Ryan, did you have one you wanted to dive into?
I'm just scrolling through them right now.
So here, can specialists like ENT, ortho, GI continue providing telehealth services for non-emergent visits if the patient is scheduled for follow-up but wants to stay home? And I guess the short answer is yes. That's kind of, well, no. The short answer is Medicare would say yes. As we just said, Medicaid, you kind of have to know what's going on in your state, and each private insurer, you have to know what's going on. But I know what I would do in your shoes. I would do those via telehealth. And to me, this is easy peasy. I would do them during telehealth. Sometimes it's better to ask for forgiveness than permission. But what I might do is I would send an email to to the private payers and say, we're doing this. Let us know if you've got a problem with it.
Yep.
There's a question that I don't know the answer to, but that is something to have on your radar as providers is, do health insurers have the option to not write new policies or add family members to policies? For example, during hurricane warnings in Florida, for example, insurers will not write coverage. I have no insight into whether that is something that's out there, an issue just yet, but it is certainly something to keep on our collective public health radars.
Katie, so this is a Pacific Northwest question. They're mobilizing emergency hospitals. Do MASH setups fall under EMTALA?
I don't know. I'd have to look.
And I think
do they fall under the waiver? Arguably, based on the language of the, I'll call it potential waiver, if you've set up alternative locations for screening and treatment, for screening, maybe, right?
So I think you'd probably want to, that would be a classic one to send a thing to your regional office asking for the waiver.
Right, exactly.
If we see hospital outpatients in a clinic setting, how will the claim look? The appointment is scheduled in the hospital with a hospital MD, but due to limiting exposure, we'd like the patient and the provider to use an exam room in a closed clinic. The patient isn't a patient of the clinic. Do we just bill like we saw the patient in the hospital? Department is scheduled. Oh, this is a good one. This is a really good one. Katie?
Oh, I'm sorry. I'm reading the other
Oh,
question.
you're reading one too? Okay. So I'll try to answer. I want your opinion. Well, I don't know. I'm like kicking the can down the road a little. You're doing it in clinic space. The safest thing to do would be to bill it as a site of service 11, right? It's a clinic visit. So, Katie, if you missed it, it's I think that's what I would do. If you chose to do it at 22, your argument would be it was supposed to be a hospital visit. Just that isn't where it occurred. That's my gut.
That's a really hard one. Yeah.
That's a really hard one. That's what I feel like I'm making it up as I go along, which is why I wanted you to answer. It's what?
Is it on campus?
The question I don't think says.
If it's on campus, I'd feel better about it, because if you're off campus, you're arguably, it's a new site that's not accepted, right? So that's tricky.
Okay, we're going to have to wrap up pretty soon. We'll just look through here for a couple of more. There are a lot of questions, so I apologize. I'm sure we're not getting to some for which I hope you'll be patient with us as we're kind of flying by the seat of our pants.
One person says document. You'll have an argument, and I like that.
Well, so hang on. I just saw one of our listeners. It's great because our listeners are so good. So I called the state boards of Wisconsin, Illinois, Iowa, North Dakota, and South Dakota. The only one on Monday that said they had definitively addressed it was Iowa, and they thought it was okay. But so it sounds like someone did the work now. But this was Monday, and this is one of the problems, right? 4 days ago is an entire universe. So I have, and it's one of the things that's going to keep us all on our toes is things are changing daily.
All right. We're going to wrap up because we're past our time. I think
by 40 minutes.
Thanks for hanging out and listening to us for an hour plus.
Yeah, and reach out to us if we didn't. We'll try to get back to everyone, and stay tuned. If we might think about doing another one of these as the situation evolves, and we hope that everyone stays healthy and safe.
Yeah, hang in there. It's going to be tough, but hang in there.
Take
Thanks,
care,
everyone.